protruder type lesions. So those kinds of the lesions is very high risk of the cancer. And additionally, and the sigmoid colonies and free. So those kind of the lesions, especially in the free part, and because of the peristaltis and due to peristaltis, and the fibrosis may be seen. But for this lesion, and according to optical examination is here, and to be and the Paris nice gene 2B type lesions. And as you see here, sorry, this is the water. And the irregular shape clearly seen. And we have to give the chance for this patient. So after the submucosal injection, and the lifting may be seen and clearly, but unfortunately those kind of the lesions may be mistake and after the injection, because on the bulky type lesions and the pseudo injection and the pseudo lifting may be encountered. As you see here, the same lesions and the anal side mucosal incision was done and step-by-step submucosal dissection was performed, and we have encountered the severe fibrotic tissue, and the muscle retraction area is clearly seen. And as you see here, no submucosal layer. So we have to decide the strategy, stop or go on. In my opinion, for this patient and young patient, and the lesion are located in the sigmoid colon, so for the surgery, this is the best option. And this lesion can be removed endoscopically. It doesn't matter for us, and the team is great. But problem is that when the lesion is cancer, probably is high suspicious. So when this happens and the dissemination is inevitable.
So Fatih,
our team
Fatih,
we
can I ask
decided
you a question?
the procedure
Fatih,
stopped.
the
Do you have any question?
Yeah, the question is
Two questions.
clearly in this case, since it's a rectal lateral spreading lesion.
Sorry, Ahmad, this is not rectal.
Sigmoid.
This is going to up to about 35 centimeters from anal margin.
Sorry.
So for all practical purposes, this is distal sigmoid. So that was also the deciding factor, whether to stop or to continue.
Well,
if this were to be in the rectum, it could have gone for either intramuscular dissection or freehand full thickness dissection. So apologies for interrupting. Please ask your question.
Yeah, so the reason is because it's written as rectal, but the question goes again, before attempting to do an ESD for this lesion, do you think any imaging modality could have changed the approach before you attempt to do the ESD, meaning whether it's cross-sectional CT scan and MRI or even ultrasound?
Absolutely, you are right. In my unit in the Istanbul, generally, and the protruder type lesions, and when the lesion size and the more than 5 centimeters, and the suspicious the Paris 2B, I'm sorry, JNet 2B type lesions, before the ESD, computerized tomography should be done. And when the lesion are located and rectal lesions and the lesion size more than 5 centimeters and the lesion type LSTG mixed nodular type lesions, absolutely those kind of the lesions high suspicious to cancer, MRI or radiological assessment is needed before the attempting.
One clarification I want to make before I go to the answer question. The endoscopist who did the procedure to identify the polyp, to characterize the polyp, to be very fair to that person, this is a really difficult polyp to assess. A rounded lumen filling polyp, it is not easy to assess each and every component of that polyp. We must remember that. The next thing is these kind of polyps drag the muscle with them. So you will have muscle retraction in these kind of cases. But pathological muscle retraction is what Fateh showed right at the beginning. So he suspected that this might not be a curative lesion, and we may just end up doing a procedure to see if we can proceed. And unfortunately, despite the very careful dissection that I've seen, we could not proceed further. So that's to answer about the first part. The second thing is, I think there are three important classifications for colorectal polyps that we need to use. One is with your Janet classification to assess the depth of the invasion. Any bit of type 3s, definitely we should not be attempting. The next one is Paris classification. Any depression is it's absolutely crucial that we look at the depression, assess with all the modalities that we have. NBI, throw some dye on, change the colors of the lens, look at that again. The next one is your Kudo classification. So these are the three important things for me when I'm assessing colorectal polyp. I hope that answers the question.
Noor, I would agree with you with Fatah. If I would see this lesion, I could give a chance for this patient for in block endoscopic resection. But as you have shown for us, there is a deep muscle invasion, and this is pathological invasion. And if you could go for beneath the mucosa, we could show some pathological vessels. This is for me landmark for invasion. One of the characteristics, not only the deep muscle invasion, but also there is some few tiny capillary-like lesion which are pathological for deep submucosal invasion. So this is very nice case and a good demonstration for how it was challenging for us.
So
Especially
question,
when the
Dr.
cancer
Fateh.
area is here, as you see here. The other area is adenoma, but this area, as you see here, and different from the other part.
See, this is something very important. Within the polyp, if you have two different morphologies, that means there is some differentiation that is happening. So that's where we need to be careful.
So Dr. Fatah and Dr. Noor, since you mentioned that this is a bulky lesion that could have like a muscle retraction sign that may not be necessary, like an invasion of cancer. So in this case, ESD is difficult to do and high risk. And maybe we're not going to send the patient for surgery without a biopsy or showing cancer. Shall we do like debulking, EMR, until we reach that lesion, and this turns out to be benign, then we have not done any harm to the patient. But if you send him for surgery and this turns out to be like completely benign, then he went for surgery unnecessarily.
That's a very good question, but the definition here about the invasion can be confirmed by pathology. We can take biopsy from within the submucosa, from the most culprit area, and then assess it under the microscope.
Yes.
Does that help, Majid?
Yes, that's a great point. Yeah, thank you.
So it seems like you guys have a plan already for sending this patient to the surgical team, which is ideal for all the reasons you have mentioned. So anything you would like to add before moving to another room?
I would like to add, I have seen Fateh dissecting every single bit of it very, very minutely. And a couple of learning points, even for endoscopists who do the submucosal work, he has used two things differently. One is the TXI. TXI has used it for submucosal work. And you can see how the texture enhances within the submucosa. This is the first time I have seen TXI being used. I've used TXIs in various different areas, but this is one of the highlights of today's case.
Yeah,